So ventilation involves a patient, an ET tube, and a ventilator. We provide ventilation to patients via positive pressure ventilation. We normally ventilate using negative pressure when we're not on a ventilator because we suck in to take in a deep breath. But when we place somebody on a ventilator and we inflate that cuff, we inherently take away that person's own PEEP, and we are ventilating them by pushing air in. So, ET tube is inserted in the trachea, above the carina, right left main stem, pilot balloon inflated. There's 4 reasons why we intubate patients. Hypoxic respiratory failure, which is an oxygen issue. Hypercapnic respiratory failure, which is a carbon dioxide issue. A GCS less than 8, or when we say intubate for airway protection because somebody's not awake. Or severe acidemia when they're on the verge of cardiovascular collapse. So the purpose of the vent is to maintain homeostasis between carbon dioxide and oxygen. So there's four adjustable variables that we use for ventilating patients: respiratory rate, tidal volume, FiO2, and PEEP, which there's details in the slides, but we don't need to go over that. The other things that are adjustable are flow rate, inspiratory time, and essentially are the same. If you change the inspiratory time, it will, if you decrease the inspiratory time, it'll increase the flow rate and vice versa, which is relevant to certain vent settings, but we're not going to go into it too much because it's very much an RT thing. So as far as vent settings go, what we most typically use is volume-based ventilation or pressure-based ventilation. I want to put this where people can see it, but sorry, Marty. So volume control is much more common. On these Hamilton vents, it's called APV-CMV, I think, right? Which is just their fancy nomenclature. It's essentially the same thing as assist control, volume control, continuous mandatory ventilation, where we set a tidal volume, the ventilator is going to give that tidal volume, and what's going to adjust, we set the rate and the tidal volume, what's going to adjust is the pressure in which we are delivering that breath. So that's based largely on the patient's lung compliance, which we do talk about a little bit here in the next slide. But if a patient on AC, if a patient tries to initiate a breath, AC will say, oh, you want to take a breath. I'm giving you 450 every 12 times a minute. So every 5 seconds, I'm giving you 450. You want to take a breath, I'm going to give you 450. So what that can do is lead, for some patients, if they're over-breathing the ventilator, over-breathing or desynchronous with the ventilator, CMV, assist control, volume control, inherently can result in like a respiratory alkalosis because we are forcing the patient to take 12 breaths a minute, and if they're not totally sedated, they might take an extra 8. And that's fine, but we have to ensure that they're not giving themselves a respiratory alkalosis, which is different from other vent settings, such as SIMV, which won't give the patient that targeted tidal volume if they should initiate it. Anyway. So the ventilator adjusts the pressure to achieve, I'm on slide, whatever, 5, sorry. The ventilator adjusts the pressure to achieve the target volume. So you're gonna see a lot of variable pressures detected within the airways when people are on assist control, because anything can change. A turn, a cough, anxiety can potentially change your airway pressures depending on what the patient is doing. So that's usually fine, unless we're really worried about increased airway pressures such as an ARDS, severe pneumonia, severe COPD, severe congestive heart failure, pulmonary edema, so forth. So I do talk a little bit about plateau and peak pressures, which we can come back to, I guess, if we have time. So a word on lung compliance. In volume-based ventilation, we set a certain volume, like I said, at a certain rate. The ventilator will tell us what the airway pressures are. If the compliance is high, like in a 40-year-old encephalopathic person who doesn't have lung disease, If we give them a certain amount of flow, it will result in a beautiful target volume because their lung compliance, their lungs are very stretchy, their compliance is good. But if they have poor compliance, we can use the same amount of flow to try to deliver that breath and they only get a volume of 250. It's like blowing up a balloon and that initial breath is like, takes more force to increase, which is kind of more like PEEP, but in any case. When you have poor lung compliance or stiff lungs, ARDS, pneumonia, pneumothorax, pulmonary edema are the primary causes for stiff lungs, then the airway pressures are gonna have to be higher, which can lead to barrel shock, as we know. Pressure control ventilation is just the exact opposite. We set a specific pressure that we want to see in the airways. The ventilator will deliver whatever volume that the patient wants or that can be delivered based just specifically on the pressure that we set. So the volume can change dramatically depending on what's happening with the patient in that case. Oftentimes we're using pressure control because there's either poor lung compliance and we want to really control airway pressures, or as an alternative to volume control because vent synchrony is a challenge and we don't necessarily want to be forcing, so if we don't necessarily want to be forcing a breath in if somebody is very synchronous with the ventilator breaths that we're giving them. So pressure control can allow for a patient to be desynchronous, but the ventilator will say, okay, you want to take a breath now, but we're going to make sure that we cap this airway pressure at 30, so you can keep breathing, but we're not going to stack breaths and allow your airway pressures to go up to 45 or something like that. So pressure is the constant, tidal volume is the changing variable. Boom. PEEP. PEEP is great. PEEP is important. PEEP is, we all have PEEP. We all have about 2 to 3 centimeters of water of PEEP intrinsically in our bodies right now as we breathe negative pressure. This prevents our lungs from totally collapsing at the end of exhalation. Pull up, breathe out, our lungs still stay a little bit inflated. And that's to keep our alveoli open so that we can have gas exchange throughout the entire process of inhalation and exhalation. But as soon as we put somebody on positive pressure ventilation and inflate that cuff, we have removed their PEEP. We've taken it away. So if we don't give them PEEP through just a tiny little flow of 5 centimeters of water constantly throughout all expiration, this is what forces these little alveoli, these air-filled sacs, the distal part of our lungs. This is what allows good gas exchange between oxygen and carbon dioxide. So having a minimum of 5 of PEEP prevents alveolar derecruitment, or prevents essentially atelectasis. It helps prevent the alveoli from collapsing. This is where the good balloon analogy comes in. Is you've got a collapsed balloon, and we've all done this, where you initiate a breath, or you initiate to try to blow up the balloon, and it takes extra force. When you first are trying to blow in a balloon, that's what it's like to blow up a collapsed alveoli. So if you keep the alveoli open, then it's much easier to continue to blow breaths into that balloon, right? Unless if it collapses, it's more difficult. So we use PEEP anywhere from 5 to 20. PEEP is, well, I won't go into how PEEP necessarily affects airway pressures right now, but if people are on pressure support, or you're providing pressure support and they have an intrinsic PEEP, they kind of work negatively against one another, so you do have to kind of take that into consideration, but I won't go into details with that right now. PEEP is a good thing. Pressure support is neither pressure control nor volume control. It is a spontaneous mode of ventilation. It is the spotter at the gym for people who are trying to wean off the ventilator. It is them doing the initiation and the spotter just saying, ugh, and helping them get that breath in. So the breath is controlled, the breath volume is controlled entirely by the patient with consideration of the pressure support that we're providing. So a great pressure support trial, which we use to assess weaning or readiness for extubation, is typically starts at about 10/5. 10 is the inspiratory pressure support that we're providing only if a patient initiates a breath on their own. For pressure support, our ventilators are really smart, so they have built-in safety tools to make sure that people don't go apneic and we just let them stay apneic, right? It kicks in at 30 seconds or whatever pressure, whatever time the vent kicks in if somebody's apneic on pressure support. It's not targeting a tidal volume at all. It's allowing the patient to initiate the breath, and it's just hitting them a little oomph with 5 continuous of PEEP. You need at least 5 of inspiratory pressure support to overcome the resistance of that ET tube. So that's why we never go less than 5/5 on a ventilator, unless you really want to make it difficult for somebody to breathe. So a little bit next on non-invasive ventilation, because it's really important, we use it a lot. The first one is CPAP, continuous positive airway pressure. This is essentially just what we just talked about, which is PEEP. PEEP and CPAP are basically the same thing. CPAP, we use, it's obviously an external or non-invasive ventilation mask put on the face with continuous positive pressure. It's best for people who are hypoxic, have primary hypoxic issues. It doesn't fix ventilation, it fixes oxygenation. BiPAP, on the other hand, is a bi-level positive airway pressure. So it adjusts the pressure based on inspiration versus expiration. It very much mimics, it's the most, it mimics what assist control can do. It's best for hypercapnic respiratory failure. So it will, with the pressure support, with the inspiratory pressure, you can still kind of sort of target a tidal volume that you don't target with CPAP at all. CPAP doesn't, you don't target a tidal volume, you just have a backup rate and an airway pressure. That's it. The patient is responsible for the rest. BiPAP, as you know, we can dial in backup rates. We can and adjust the pressure to target a specific tidal volume, specifically for patients if we're trying to help them blow off that carbon dioxide. And then there's AVAPS, which is a newer setting. It stands for Average Volume Assured Pressure Support. This basically is BiPAP, but it's a little bit more sensitive in that it's adjusting the airway pressures to still target that tidal volume. So instead of setting pressure that we want the BiPAP machine to do, in AVAPS we can set a target volume similar to assist control on the ventilator. And then the AVAPS, the machine, the Trilogy usually is what it is, will adjust the pressure to deliver that targeted breath. How much time we got?
You could do like 5 more minutes.
Okay, all right. First of all, any questions or anything that anybody wants me to clarify or go over, or? I do want to go back a little bit to this slide on volume control. For tidal volume, the older school of thought used to be about 10 cc's, 10 mLs per kg of ideal body weight for target tidal volume. There was a huge study that came out several years ago called ARDSNet. It was a humongous trial on ARDS patients that proved that lower tidal volumes by far improves outcomes and reduces risk for barotrauma and allows for permissive hypercapnia. Permissive hypercapnia is what allows us to adjust the ventilators to help get patients extubated. If we're over-breathing them all of the time and giving them a respiratory alkalosis, we have a very difficult time backing off on our vent settings to get people off the vent. So our target tidal volumes now are typically 6 to 8. 8 I'd say is average, 7 to 8 they see a lot of. 6 is a much smaller tidal volume. We use that, we're typically in patients that have real ARDS or have a lung compliance issue where we're not wanting to target large volumes to create higher airway pressures. So, and it's based on ideal body weight, not their actual weight. Ideal body weight is calculated off of their height and weight. And then finally, the very last slide, I was just gonna start on my to be continued slide, for the next go around, which we can talk more about the specific types of acute respiratory failure and hypercapnic respiratory failure, but one thing I wanted to mention is on the ventilator, if you have somebody who's got hypoxic respiratory failure, they have an oxygenation issue, there's two things that we can really adjust to affect their oxygenation. They are the concentration of the FiO2 and peak. Those are the two things that affect oxygenation. Adjusting respiratory rate or tidal volume will not affect your oxygen. It affects the carbon dioxide, which we refer to as ventilation. So when we talk about saying somebody, we have a hard time ventilating them, that's not an oxygenation issue. When we talk about ventilation, we talk about their ability to clear the carbon dioxide. So you can think of that when you're interpreting your ABGs or your VBGs in the morning and deciding, well, this person is hypercapnic, what would I adjust? And it would be, you would be looking at adjusting respiratory rate or tidal volume.
Yes.
And that's the decision, and what we adjust
Yes.
there is largely dependent on the patient's lung compliance. What are their airway pressures? And how much more volume can they tolerate before putting their pressures too high and putting them at risk, etc. To wean somebody from the ventilator, FiO2 less than 60%. If you've got somebody that's really got severe hypoxic respiratory failure, we wean FiO2 before we wean PEEP, always. What else? Trying to think of other little quick nuggets I can throw in, but maybe that will do it. Any questions?
Elizabeth loves this topic, so she was putting it together and she's like, I need a part two.